Have you got it, Dr. Silva?
Yeah, no, I have his email. I'm sending it by email as well.
Okay, thank you.
There'll be a bit of breaking on the video.
Global Wisdom Missions, a ministry with global impact. Global Wisdom Missions is an organization of Christian ministers from different denominations and countries dedicated to presenting Jesus personally to this generation of the young minister and leader by assisting them to fulfill their calling by following and applying the wisdom of God. Our vision is to be a global conference that raises a generation of gospel-centered, gospel-driven, and gospel-focused ministers of Christ, who shall proclaim the gospel with integrity, purity, simplicity, and without adulteration. We are achieving our vision through educating ministers and leaders through our weekly broadcast of the Wisdom Conference on Facebook and YouTube Live, which is making a global impact. Wisdom Impact Magazine, our quarterly educational, inspirational, and informational magazine, which will be printed in hard copies and be distributed globally free of charge to countries and territories which may not have access to internet. The Global Wisdom Academy, an online ministerial and leadership training academy which remains steadfast and committed to carrying out God's purpose of empowering Christian ministers and leaders globally to effectively execute leadership and ministry work with wisdom. Global Wisdom Missions' aim is to proclaim the gospel in word and deed, describing the shape of Jesus' own ministry. The Apostle Peter says he went around doing good and healing all. Through missions, we seek to provide healthcare for a lasting change during our actual Global Wisdom Conferences in different countries with our skilled medical physicians, experienced surgeons, and professional health workers. Partner with us now and help us spread the gospel of Jesus Christ around the world and take it to places where you may not be able to go yourself. Together, we can make a difference in somebody's life today. To give your donation, visit our website at www.globalwisdommissions.com and donate via our PayPal link or register your interest at wisdomconference3@gmail.com.
Hello.
Hello.
Good afternoon and good evening, everyone. And thank you for joining us once again on the Wisdom Conference, Time with the Doctors. And for today, we have a distinguished panel, and we are going to discuss COVID-19 and the vaccines. We've talked about on this forum several times, you know, we are children of God and we are doctors, and we believe that God has given us the wisdom and the knowledge to help his people. Jesus said that it is the sick who need the physician. And as we've talked about in the past, Luke was called the beloved physician. Luke was a disciple, and he was well liked. Paul always referred to him when he was writing to the churches. And so it's important for us to understand that, you know, having doctors is part of God's plan for us. God has given us the wisdom. The Bible talks about the fact that, you know, the leaves and of the trees that he has made, you know, are for healing of the nations. And God has given us the wisdom to do that. And so today we are going to discuss COVID-19, which has become an issue that everyone around the world, you know, is affected by in one way or the other. And it's important for us to address this because there are also many myths and many conspiracy theories out there that is depriving people of knowledge and also depriving people of important therapies. And so we're going to go about this. Some of you may have heard negative things about the vaccines, and we will try to address it. And as we discuss this, you can send in your questions live and we will answer them. So before we start, I will introduce myself and the panelists will introduce themselves as well. Professor Jonathan Lawye. I'm a professor of surgery at the University of Arkansas for Medical Sciences. And I have been kind of the co-host of this program since it started. And so I'll hand over to Mrs. Mordlate, and then we'll go around and everyone will introduce themselves. Thank you.
Thank you, Dr. Lai. Thank you, Professor Lai, actually, and thank you for the fantastic start. So viewers, thanks once again for joining us for tonight's edition of Time with the Doctors. And like Professor Lai rightly said, we are going to try and find out, or at the end of the session, our doctors are going to help us to know the facts from the fiction, so that if we are having conversations and if we are making decisions, they are going to be informed decisions. And today I'm your hostess, and I'm very privileged and honored to have these lovely panelists with me. Dr. Beth, could you please introduce yourself to us? You're muted. You're muted.
Yes, thank you for having me on the program. My name is Dr. Beth Ayi. I'm an infectious disease specialist. I graduated from medical school 24 years ago. I spent some time doing training as an internal medicine physician at Good Samaritan Hospital, affiliated with Johns Hopkins. And then I did an infectious disease fellowship at the University of Nebraska Medical Center and Creighton University in Omaha. After that, I've worked in the Midwest. I'm currently a consultant in infectious diseases in Essentia in Fargo, North Dakota. Since April of this year, I was appointed to the Case Management Working Group of Africa CDC. We meet every week and look at Africa CDC's COVID-19 cases and discuss them and plan around them. And so I have some insight on what's going on the continent. And then from about May to September of this year, I was on TVC every day, as well as Ghana TV, discussing COVID-19 and educating people. And I've done a lot of advocacy work on COVID-19. I've also received my vaccines. And so I think that qualifies me to talk about COVID-19 vaccines and allay people's fears. So, and Jonathan and Leonard I've known for probably 20 plus years. They were a year behind me in medical school. So I've known them for a long time, and I'm happy to be here at their request. Thank you.
Thank you so much, Dr. Ayi. Dr. Forbes, could you please introduce yourself to us?
Yes, hello, I'm Kate Forbes. I'm a GP, which is a general practitioner in Southampton in the UK. I've been a doctor for about 35 years now. And unfortunately, I caught COVID at the beginning of the first wave, actually, in March, which has kept me out of a lot of work, unfortunately. I'll talk about it a bit later, because it's actually quite an important problem now that we didn't realise in March. Yeah, I think I'll be quiet now. Let everybody else introduce themselves.
Thank you. And Dr. Jane, please.
Hi, yeah, thank you for having me. It's an honor to be here. I'm Dr. Jane Jura-Bonblatt. I trained in internal medicine initially and then went on to do epidemiology and public health fellowship. And now I work exclusively in public health, including vaccine research and safety. Currently in the federal government, U.S. federal government. And I should say that the views expressed on this program are my own and do not represent the U.S. government.
Thank you, Dr. Jane Bonblatt. And Dr. Leonard Sowa, please.
Dr. Leonard Sowa. I also trained, as Dr. Ayi said, with her and Dr. Jonathan in the University of Ghana And since then, I've done my Master's of Public Health in Hopkins. I've done residency in internal medicine. I have I'll say a strong interest in HIV, so that's actually where I work mostly for most of my career. Currently, I do mostly HIV and viral hepatitis research. I've done some work in COVID because of the fact that COVID came on us. We weren't prepared for it, and a lot of people had to be pulled out from what they are doing to do some COVID work. So I've also had some COVID experience, mostly working with reviewing protocols and things like that. I also have to say that as a federal employee, whatever I express in this program are my personal views and not the views of my employer. Thank you very much for inviting me.
Thank you once again for accepting the invitation. Now, I feel really honored to have you all on board. Now, viewers, we are so lucky or blessed to have these amazing guests on our show tonight. And the truth is, if you are not sharing the program, then it's of no point because they know all this information and they are happy to share it with us and we don't have to pay them anything. So they've sacrificed their time, their lovely Sunday afternoon, Sunday evening, and then they are just ready to share. Now, what we can do is just to share this information. And it's amazing how the wrong information gets out there really quickly. Now, these are factual things that are coming out. These are not fabrications. These are researches that they've done. And these are valid things. So I would implore you all to just share. Kindly share with your friends, call your family, call your friends, call your neighbors to come and be part of this good thing. So Dr. Bertha Ayi, we've all had conversations lately at our dinner tables about COVID, coronavirus, SARS-2. Could you just help our viewers to understand? And I'll kindly ask you to use your very simple English words to explain it so that our viewers all over the world who do not have medical background like myself would understand it. Thank you.
All right, thank you very much. So the word COVID-19 was coined to reflect the infection with SARS-CoV-2 virus. And the COVID just means corona for the CO, V for virus, and ID for infectious disease of 2019. So that's where we derive the word COVID-19. Coronaviruses were first discovered in the 1960s as the cause of the common cold. There were just 2 of them at the time. And then in the 1980s, 2 more were discovered. And the word corona is just another language for crown, because as you can see in the multiple pictures that are shown of the virus, it's a round virus with little spikes or crowns on its head. In 2003, there was an outbreak of SARS in the world, in China. It was quickly curbed. And there was another outbreak of what we call the Middle East Respiratory Syndrome. They were all due to coronaviruses. So this one that broke out in December of 2019 is the world's 7th known coronavirus. And it was termed SARS-CoV-2 to differentiate it from the first one that caused SARS. And so the SARS just stands for Severe Acute Respiratory Syndrome virus caused by the corona. So that's the difference between the coronaviruses and the SARS-CoV-2. And so, you know, most people say, oh, I got COVID. So COVID is the name of the disease. COVID-19 is the name of the disease, while the SARS-CoV-2 is the name of the virus itself. So I hope that explains it. And the difference between a pandemic and an epidemic, I don't know if you remember, but until March 11th, it was being called just an epidemic. The WHO was slowing down in terms of calling it a pandemic, because an epidemic is when you have a disease occurring in high frequency than is normally noted in a particular area. And so we just felt there was an epidemic in China. But then as it got to a lot of countries and it became global, we then called it a pandemic. And so on March 11th, it was declared as a pandemic. And so how deadly is coronavirus? The mortality, meaning the number of people who would get it and die, is between 1 out of every 100 or 4 to every 100. Although I must say that in the last month or two, in a few African countries, the mortality is gone up to about 7 to 9%, which is really high, meaning 1 out of every 10 people who get this disease will die from its complications. All right, Maud, I think we can't hear you.
You're muted.
We all fall for this, don't we? You think you've done it so many times and still you're muted and you don't even remember to unmute yourself. And so I said, thank you very much for that very thorough definitions and explanations. And like I was saying, I like the fact that with your stats, we could actually appreciate the fact that 1 in 10. So it means if you know 10 people, 1 out of the 10 could actually die from COVID-19. Thank you. Dr. Kate Forbes, could you please talk us through some of the risk factors of COVID-19?
Okay, so there are various risk factors. One of the largest risk factors is age. The older you get, the more likely you are to get it severely, well, symptoms anyway. Anyone can get it, but not anyone has the symptoms. Not everyone has the symptoms. And very often children will just present with a cold or a bit of a temperature and nothing much else. And but the elderly can be very badly affected. In fact, during the first wave in the UK, many of our old folk in homes were absolutely devastated. We had a lot of deaths in our residential homes. The other factor is obesity or high BMI. So if you are overweight, you're more likely to get symptoms of COVID. So at the age of 58 and quite round, well, more than quite round, quite fat, I posed quite a high risk of getting COVID, and I got it. The other factor is underlying health problems. So things like high blood pressure, diabetes, cardiovascular disease, things like that, which are often associated as well with obesity and age. But those things in themselves, if you're younger and you have those things, it can also increase the risk. The other factor is if you are of African or Asian, or as we would say in the UK, BAME, Black and Asian ethnic minority groups of people, there is a much higher risk. The other risks that we have been seeing are people who are living in overcrowded and cramped conditions. Often people who are less affluent, so poorer people it tends to go through families. And I think more recently it's been thought that there may well be a genetic factor as well. So there are risks. So essentially, if you are older, fatter and sicker from other things, and from a Black or Asian ethnic group, you're more likely to get it, and more severely. Would you like me to just carry on, Maud?
Yes, please, Kate.
Yeah, okay. Because it's a novel virus, it's not one that that human beings have seen before. Our immune systems, I think it's thought that probably the way our immune systems react to it causes a lot of the problems. And the first part of the virus, first part of the infection is often characterized by a raised temperature, a cough, aches and pains, flu-y type of symptoms. Often you can get gastrointestinal problems, so maybe some diarrhea, abdominal pains, muscle aches and pains, an odd cough, actually quite severe pains as well. And that may well then settle after a week, but then become more ill again as your immune system starts to fight the infection. Because often, if our immune systems are not as young as they were, so that's why it affects the older people, your immune systems can go into overdrive, and it's very often the overdrive that's causing the problems. There are a lot of problems with people who are severely ill, with clotting, inflammation problems within the body. So people can have severe pneumonitis, that's severe chest inflammation, chest infections and pneumonias. They can have myocarditis, which is inflammation of the heart. They can have vasculitis, which is inflammation of the blood vessels. All sorts of things. It affects every part of the body, and when people have it very severely, it can cause strokes, clots in the lungs, all sorts of things. It's a nasty, nasty illness. How to avoid it? Well, first of all, the best thing is to try not to catch it. That's the most important thing. Try not to catch it. The best way to not catch it, because the easiest way to pass it on is to get close to each other. It's a virus that likes human company. It's a virus that likes you to be close to each other. So if you start standing close to each other and talking and sneezing and coughing and shouting and singing right next to each other, you are very likely to pass on the virus, because it's a respiratory virus. First and foremost, although it has effects throughout the whole of the body, it first and foremost is a respiratory virus. So anything that means that you are in close enough quarters to inhale somebody else's exhalation. So if you are within 2 meters of somebody, then you're more likely to catch it. If you are indoors a lot, then you're more likely to catch it if you're indoors. So there are a few things that you can do. First of all, stay at least 2 meters from each other. Open windows. If you're inside, let lots of fresh air through, because if you've got lots of air movement, it dilutes the virus and it blows it away. As soon as you've got stagnant air, the virus stays there and you're more likely to breathe it in. You'll get a higher concentration of the virus in the air and you're more likely to get sick from it because you will have more virus in your body. So open the windows, put on a mask if you're with people that you don't generally live with. Go outside. If you want to meet somebody and you have the option, go outside and meet them, because outside you're far less likely to catch it because the fresh air will blow the virus away. The other thing you can do, and that is a really important thing, is to wash your hands regularly, because the virus can settle on surfaces and you can put it on your mouth and you can pick something up and you touch your face and you touch other things and your snot and your stuff around your face. That's it. So basically it's put a mask on, keep your distance, wash your hands, open the windows, and if you can, meet outside. What else would you like me to talk about, Maud?
If you could talk about long COVID, please.
Yes, I can talk about long COVID with great authority. So I'll tell you what happened to me and what I oh, there's a question here. I'll talk about long COVID first. Okay, so the day after lockdown started in the UK, I started to feel quite strange. Had a bit of a temperature, felt quite washed out and felt very odd. So went home, I thought, oh, I think I've got it. Went to bed and slept for 2 or 3 hours and woke up with a horrible cough, which was really quite unpleasant, and felt completely spaced out. Was just not here with us, and I just didn't have any energy, and I just felt very, very odd. And then after about a week, I started to feel quite a bit better. But about 8 days, I started to get quite wheezy, and the cough got worse, and I felt very strange, and I felt really quite unwell. I started to get very short of breath. I felt dreadful. I had really severe chest pains here going up into my mouth. I felt awful. And at that time, the UK was just saying, well, you stay at home, you'll have a cough, you just have to wait for it to go. And there actually wasn't a lot of support because I think it wasn't understood. Subsequently, we found out that I probably actually had quite a significant pneumonia at that time, although it wasn't obvious particularly, except I felt so dreadful and I was very short of breath. The cough and the shortness of breath continued for about 3 months. And the feeling foggy on thinking continued, and actually continues to this day. If I spend too long doing anything, I will just lose concentration. It may be at some point, if you start noticing if I lose a few words or I start looking a bit vacant or stuttering a bit, it's not because I'm stupid, it's because the long COVID has that effect on me. And if I've been concentrating for any length of time, I won't necessarily be that coherent. The other thing that happens is my voice goes. Now, I'm just one group of people who have long COVID, who have these particular symptoms, things like brain fog and getting very tired. There are other groups of people. There is a wide range of symptoms. Some just get very tired, and other people have problems with palpitations, with shortness of breath, with ongoing chest problems and ongoing problems with angina and myocarditis. You know, there are problems that can continue. You're slightly more likely to have it if you are a woman, and the highest age group is I think just under 50, that group, and then the just over 50s is the next highest. So it's a significant problem, and it's thought that probably maybe 1 to 10 or 1 in 20 people have a significant long COVID symptoms. So we didn't know about this in March. We didn't really know about this in June, because I was one of the first people that probably have developed this, of the first tranche in the UK. And it's only really starting to become more apparent that this is an issue ongoing. We don't know how long it's going to go on for. I don't know how long I'm going to be like this, but I know I'm getting better. Who's to say? The people who had SARS when that was around had apparently a very similar problem after it as well, and that people did recover. So there is hope that people will recover, but it does give some long-lasting problems. And I've also been left with asthma from this because of the inflammation in my lungs, and I now have to take an inhaler daily, which I didn't have to before. So it's significant. The question is, you said it's affecting Africans, Asians and Hispanic more. Is this a reality? Is that reality for America, or is it the global picture? Well, I think that probably I can't answer that completely. All I can answer for really is the UK, and I suspect also for America. But I think was said earlier that the rate of death, mortality, is increasing in Africa at the moment as well. Is that right?
Dr. Ayi, do you want to chip in that?
Yeah, I think at this point, I think we it's like a pendulum. We swung from thinking that originally, when there was an outbreak, that some people thought that Africans were actually immune because there was a 21-year-old Cameroonian in China who recovered. And so people just run with it, that one was representative of all Africans. And that I was trying to tell people that he's a young man, and so he probably recovered very well from COVID. It doesn't mean it won't affect Africa. And then by mid-February, Egypt had a case, and we now know the rest is history. Now, initially, Africa had very few cases. So to answer that question, Dr. Kate talked about how it spreads. It's how close you are to people. And so one of the first things that came out of the United States and the UK, that it was disproportionately affecting people who are Black, not necessarily African descent. And the only reason was the fact that this disease is also a measure of sort of socioeconomic conditions. If you have more people living in a house who don't have access to healthcare, and it just turns out that a lot of Africans in the US and also in the UK may not have as much access to healthcare. They may have more diabetes, they may be more overweight, and so they just happen to have risk factors. And so while Africa was recording almost few cases and people were writing about it, Africans or people of Black descent in the UK and the US were having skyrocketing cases. And we will tie that in with vaccines at this point, because some people are asking, why are they targeting people, minority people, to receive these vaccines? So I won't delve into that. But while there were more Africans getting infected in the UK and in the US, there were few cases in Africa. And so people took it for granted that, we said it, that Africans are immune. But unfortunately, over the last month, most African countries have experienced quite an increase where the case fatality or the number of people who would die was about 1:100. In some countries, is up to 9%. And so that's very concerning. So the summary is that it's not as though this disease goes to look out for Black people or people of African descent or Asians, but it behaves the same way with every skin color. If you put yourself in a situation where there's overcrowding, or you're close to a lot of people, or you're not wearing your mask or social distancing, and you have diabetes, obesity, and all these risk factors, then clearly the disease will be predominant. So that is just to clarify the question on race. I hope that helps.
I think that's a very good explanation. Thank you, Dr. Ayi and Dr. Forbes. Dr. So, I'm going to come to you very quickly, and then I'll hand over to my co-host, Dr. Lai. Now, my question for you is, like other viral diseases, like about a year ago, actually, my younger twins had chicken pox. But thankfully, I had it already, so I didn't catch it. And so did my older girls. They didn't catch it too. And so with other viral illnesses. So my question is, if you have COVID, are you immune to it, or is there a chance of you getting it again? And if you could talk to us about herd immunity very briefly, and then I would hand over to you, Dr. Lai, please.
All right. Thank you very much for this question. And this is a very important question. When it comes to viruses, every virus is different. And so some of the viruses, when you get them and you get cured, you pretty much are immune for life. But other viruses, when you get it, you don't get immunity. You may get some type of immunity, but it's not complete. And so every virus is different. I'll just talk a little briefly about the cold virus. We'll talk a little bit also about the flu virus. So that's how things go. Then when you come into COVID, we have a virus that we also don't know a lot about. And then the other thing that is coming in the midst is the fact that the virus is also changing. So as of now, what we know is that yes, there is some degree of protection when you get the infection. The question is, how long does it take? We don't know yet. And even though we also know there is protection, we still have reports of individuals who've got repeat infection. Even within, we most probably will say that 90 days you are okay, but even within the 90 days, you get some reports of people getting 2 cases, that is within these 90 days. But overall, though, if we are going to look at previous information, and when I say previous information, from the first SARS infection in 2003, we do know that there's protection that can go as far back as almost, and I know some people say 110 days, some goes as far as 250 days. But it's not going to be the same for everybody, because everybody is different and everybody's immune system would be different. At this point in time, from the vaccines that are available, we know that it protects for about 110 days. As time goes on, we'll know more. And then herd immunity. Herd immunity is a very important thing, and herd immunity has protected us from a lot of diseases. I'll briefly talk about polio. You know, a lot of places in Africa, we don't even know, even where we used to have polio, we're not getting polio any longer. And it's not because everybody got a vaccine for polio, but what happened is that a lot of people were able to get a vaccine. And when a lot of people get a vaccine, what happens is that the people that got the vaccines and got protection became the guards of the herd. And the idea of herd immunity is something that animals use when they are moving around in the jungle. And the stronger animals are the ones at the hedges, and the weaker ones are within them. That way, when the lion comes to attack, it actually has to deal with the strong animals first. And the lion may not be able to get the strong animals, and the weaker ones are able to be kept safe. And that is where herd immunity comes. Herd immunity is a community thing, but it doesn't start with the community. It starts with the individual. Because if you say, I'm an individual, I don't need the vaccine, what you are doing is that you are weakening the herd. So the more of us get this vaccine, the more likely we are to get herd immunity. And before I stop, I'm going to also talk a little bit about getting herd immunity from vaccination. And I'm going to say that with kids among us, nobody should be herd immunity from getting the natural infection. Nobody should be thinking of us trying to achieve herd immunity with natural infection. When we're talking about it long there in February and March, we didn't even know about long COVID. But now we know about long COVID. So if we are trying to even think about getting herd immunity by getting more people to get infected, we're going to have a lot more long COVID among us, who we don't know how to treat, who we don't know how long they're going to be sick for. We should be very, very careful about talking about herd immunity in that sense. But we can get herd immunity by getting more and more people vaccinated. The numbers will change because the virus is changing, but the more people that we get vaccinated, the more likely we are to achieve it.
Thank you, Dr. Lai.
Okay, thank you so much. I think we are really having fun answering these questions, and I would say that if you have questions, you can send them in, and we'll try to address them, as we go along. So we're going to switch topics to the vaccines now, and I'll go to Dr. Bomblatt first. So first of all, if you can, maybe before we even delve into this, but vaccines for COVID, if you can briefly just tell us how vaccines work, and then we will like to know kind of how many vaccines are currently available, and Dr. Soa can chime in. How many vaccines are available currently around the world, and then we can go into some details. So thank you.
Sure, happy to talk about vaccines all day. So vaccines are our primary mode of infectious disease prevention worldwide. The aim is to use your body's own natural God-given defense against disease that you might come across and give you immunity so that if you're ever exposed to the actual disease, which could actually kill you or cause what we call morbidity, which Dr. Kate talked about long COVID, that you have natural immunity to it. So that's all a vaccine is. It's using what we've already been given to create immunity without having the disease. So in vaccine development, we lump them into 3 different buckets, or what we call platforms. So you have the whole virus. You could give a whole virus in a weakened or inactivated state so that it cannot cause disease. You can give bits of the virus, what we call subunits or proteins, or you can give genetic material, which is more what we've been hearing about most recently with the mRNA vaccines. And so these are the different platforms that you can use. They have pluses and minuses, and depending on what disease is being targeted. So the number of COVID vaccines out there right now is increasing, which is a good thing. But currently we have about 10 different vaccines that have been authorized and are being rolled out in different countries, and 2 more coming up for authorization. In addition to that, there's about 200 candidates currently in development and 60 in clinical trials. So we have the big ones that are given to more people now, Pfizer and Moderna. They have the mRNA platforms, and then we have AstraZeneca's Johnson & Johnson and the Russian vaccine Sputnik. These all use adenovirus vector vaccines, and that just means that they use a different virus with which to introduce the subunits to your system. And then there's other ones. There's CoronaVac, there's Covaxin, there's Sinopharm. Different countries have been involved in the production, different pharmaceutical companies, and these are all in the pipeline. They have very good immunity. I think we were surprised when we saw efficacy in the 90s for many of these. The lowest that I've seen is Sinovac from China, which is only 50%. But bear in mind that we have flu vaccines that are 50%, and we've been taking them for a long time. So 90s is really, really good, and I don't think that anybody expected that. And I think that's just pretty amazing that these vaccines did that.
Okay, so thank you so much for that. There is a question which I would kind of partly answer and then also kind of toss to the panelists. So one of the questions is the ingredients in the COVID-19 vaccines, like potassium chloride, is administered to people on death row to give them cardiac arrest. So the truth is that we use potassium chloride all the time in the hospital. When patients are in the hospital and they have low potassium, we give them potassium chloride all the time. In fact, it's probably one of the commonest things we give. For me as a surgeon, our post-operative patients, those that we do major surgeries on, most of the time we are having to replace their potassium. So potassium chloride is something that we use all the time. Now, for people who are on death row, the dosage of potassium chloride that they give them is massive, and that is what induces the cardiac arrest. And so having potassium chloride as a component in a vaccine is nothing to be worried about. Potassium chloride, there are many people around the world who take potassium chloride as well every day, especially those who are on diuretic, so fluid pills. And one of the commonest medical conditions in the world is high blood pressure. And one of the treatments for it is a fluid pill, diuretic. The most common one is called Lasix around the world. And people who take that, they lose potassium, and so they have to take potassium supplements. So again, some people take potassium every day, and so having potassium is not an issue. The second thing is that the WHO has not officially approved vaccines, and they are already being given around the world. And I think we are going to try to address that. I think people's concern was that it took such a short time to develop these vaccines, and there's not been enough time to really study them in depth. And so, Dr. Bonblatt, can you maybe address that in a short time? I mean, kind of, should we be worried about the fact that these vaccines have been developed within such a short time, and most of them are being used with emergency use authorization instead of kind of full approval? So.
Mm-hmm. Yeah, so we get this question a lot in vaccine development, and we should not worry that it's been developed at a short time. So I'll explain to you the process. Basically, vaccine development is a massive collaboration effort across continents involving governments, public health agencies, the private sector, pharmaceutical companies, international institutions, research organizations. And typically, this can take 8 to 15 years from lab to patient. I think the fastest vaccine that we had developed before the pandemic was mumps, and that was 4 years, and we thought that was like amazing. So, but in this pandemic situation, what we saw that's never happened before was researchers across the globe collaborating and accessing each other's data in a way that has just, it was pretty amazing to say that, you know, China got the sequence and then gave it to the US and then the UK. And just to see everybody coming on board because we were in a pandemic was actually pretty amazing. The researchers to quicken the process by focusing on new vaccine approaches, but also approaches learned from SARS and MERS. So some of these things were already in the pipeline from what we had done before. The DNA vaccines have been used in HIV as well. The mRNA vaccines are just, they're faster because you don't have to grow antigens for months at a time. So that's essentially what happened. The other huge thing that happened was that governments came alongside pharmaceutical companies and basically took on the financial risk that companies did not have to take. So they were incentivized to manufacture. And so before this, you would do clinical trials in sequence. So you would do phase 1 and then wait for results and do phase 2 and then do phase 3 and then take a promising candidate and then make it. What happened this time was that government said, we're going to take the most promising candidates and you start manufacturing and then we're going to see. That's a huge risk to take. And if it had not worked, we wouldn't be here today. So I think that we have very good safety data and that we don't need to worry. And I think what we saw in 2020 in terms of vaccine development, if we're believers, we should understand that this was like the grace of God, just like pointing people to the right thing because vaccines fail more than they work. And so the fact that we actually have so many candidates is actually like God's mercy in the midst of a pandemic that is killing people. So that's what I take away as a believer. In terms of why they're not approved, well, because so in the approval process, there's steps that need to be taken. For example, you need 6 months of safety data, for example. In authorization, what we said was, we're going to do 2 months of safety data, not because we think that something else is going to happen after 2 months, but because we're in a pandemic. And after 2 months of giving a vaccine, we don't think that anything else is going to happen that's going to affect the safety profile. And that's why it's authorized, because you're going to watch to see. So right now, worldwide, 200 million people have been vaccinated. And I mean, that's pretty impressive that we haven't seen any safety signals in evaluating these further. And I can attest to it as we can all that, we've been fortunate to be vaccinated. And it's pretty good safety profile.
So thank you so much for that. And to let everybody know, I think all of us on this panel, maybe with the exception of Mrs. Modlate, we've all been vaccinated. And we are all doing well. We have had no problems. So the other issue, which was relayed in the question, has to do with the mRNA vaccine. And I think there is some misinformation out there saying that this vaccine incorporates into your genetic material. I want us to kind of address that. Maybe Dr. Bombla can start, and then Dr. Soa can add something to that. I mean, what is mRNA? Does mRNA get into your genetic code, and does it alter your genetic code?
So no and no are the quick answers. But if you guys all remember high school or O-level biology, right? You have your cell, you have your nucleus in your cell, you have your DNA within the nucleus. Your DNA makes mRNA, ships it out of the nucleus into the cytoplasm, and the nucleus makes and the mRNA makes protein. mRNA just means messenger RNA. It's sending a message to the protein-making factory in your cell, telling it to make proteins. So essentially what you're doing in these vaccines is giving your cell a message, mRNA, saying, please make protein, the S protein, if you've heard that. Please make this protein, ship it out of the cells so that our body thinks that we have COVID. And then your body's going to make the antibodies, which are what fight against infection. So that's all mRNA is. It does not go into the nucleus. It does not go into your genetic code. It cannot do that. If it did that, that would be like a first ever, kind of like Jesus walking on water. It just doesn't happen, and it's not going to happen. So that's my short mRNA.
Okay.
Spiel.
Dr. Soa, do you want to add something to
So
that?
I'd like to say that mRNA, whenever I hear about the success of these vaccines, I just say that this is just a breakthrough that we needed at the right time. And the fact that it worked actually is a good thing. A lot of people think that this was something that happened in just a few months, but what we don't realize is that this research has been going on for many, many years. I did research into this, and the first time anybody actually reported about mRNA use in humans was in 2003. This is almost 18 years ago. If you had a child at that time, that child would be actually in college now. So mRNA virus vaccines are not new. What is new is that they have been successful and being used in large populations. So if we go back to 13, we've got about 18 years of history of mRNA vaccines and not seen any significant safety signal. What it tells us is that they are fairly safe. And as Dr. Bamblack said, the mRNA just goes into the cell. It doesn't go into the nucleus. You actually need an enzyme to do that, and it's not going to happen. It's not happened, and it's not going to happen.
Okay, so Dr. Soa, whilst you are there, Dr. Bamblack mentioned several vaccines that have been approved in different countries, and even a lot more that are in clinical trials, and a lot more candidates that are being studied. How effective are the ones that are on the market? So, the ones that we've mentioned, maybe you can kind of mention the names again, and then how effective are these vaccines so far?
So what I'll say is that this is another area where I think the mRNA technology is actually showing us that it does actually work a little bit better than the other vaccines that we have on the market. Because I'm telling you, we've been vaccinating people for ages, and most of the time, when we get 80 or we get 70%, we are happy. When we get 50%, we are happy.
Yeah.
When we started working on these vaccines, the target that the FDA gave was about 50%. Jane, am I right?
That's correct. Yeah.
So we actually are doing a lot better than where we were targeting. We are actually going, when it comes to the Moderna vaccine, it's 94% efficacy.
Right.
Meaning that it protects 94% of people that get the vaccine. And then when I say 94%, it means that these people do not get disease. But when you go to severe disease, meaning that you get COVID, but you don't get severe disease, the numbers go to 100%.
Right.
So for the Moderna, for the Pfizer one is also similar. Also about 100% for severe disease, and also 94% for mild to just disease. So these are very good vaccines. Recently, I know that Russians also released some data on their Sputnik V vaccine, and I looked at the data, and they are also actually quoting about 94% efficacy. And they also have about 100% protection for severe disease. So we have a couple of good vaccines on the market. The question that sometimes people ask is that, which one should I go for? And I'll say, whichever one you have, go for it.
Yeah.
There's AstraZeneca is also there. And the numbers are not as easy to quote because their studies showed about 70%. But then when you look at different populations, you realize that if you are looking at also severe disease, it goes up higher.
Right.
So a lot of the vaccines that we have on the market would definitely protect you from severe disease within the period, mostly about 14 days onwards from the first dose. Some will be a little bit late. I think the Russians said 18 days from the first dose, you get protection. So overall, let's look at it as get a vaccine, you're going to get protected mostly from severe disease. You would also get protected from infection to a certain extent, but that is a different story. What I'll say is that for most of the time, you're going to get almost complete protection from severe disease.
Okay, thank you so much. In terms of the vaccines, you know, how many doses are required? You know, is it the same for each vaccine? And there's a question out there that people are asking, you know, how do we get the vaccine? And I think we can throw that in there. I'll start with Dr. Soa, and then
so yeah, I saw that question. So when it comes to getting the vaccine, every state is different. And I saw the question, and it actually was specifically for Maryland. I think in Maryland, you have to go by your county health department, and most of the health department have a website that is actually focused mostly towards COVID-19 vaccination. Every state, though, is different. But for the state of Maryland, go through your county health department, and you can look for COVID vaccination, and then you can figure out whether you meet the criteria for vaccination at that time. Most of every state is using a different criteria to determine who should get vaccinated now. But down the line, we are hoping that it's going to get generalized by April. Everybody who actually wants vaccination can get vaccination. Unfortunately, we don't have data on children, and we'll talk a little bit more about that. So that they'll be come later. And I saw a question on the variants. I can quickly put that one in. With the variants, what the variants is telling us that when you leave the virus to actually continue to spread, you are actually going to have more variants popping up. So what we'll say is that whenever you get a chance, just get vaccinated. The more people we get protected, the less likely we are going to get variants. So far, the vaccines that we have actually work against the variants. There is some small data in South Africa that suggests that the South African variant may actually be able to overcome the AstraZeneca vaccine, but that's just small studies, and more studies needs to be done to actually figure it out better. Yeah. But once you get vaccinated, we actually reduce the likelihood of getting more variants coming up. The virus always is going to change, so we can't avoid it. We only have to slow it down.
Okay. I think the other thing to chip in is the fact that some of the studies that were done in South Africa had some of the patients in there had the South African variant, and so it is clear that those vaccine studies that were done in South Africa, they show efficacy against the South African variant. So.
And I wanted to add to that it's not like an all or nothing game here. Like just because there's reduced efficacy doesn't mean that the vaccine doesn't work. I mean, you know, we have seasons of flu here in the US where the efficacy was 30%, and yet we still saved like that number of people. So it's always a good idea, even with reduced efficacy, to get vaccinated.
Okay, so I think the first part of the question was not answered. The question was how many doses.
So most of them are 2-dose series. The two that are not currently are the Johnson & Johnson and the CanSino Bio ones from China. So those are 1 dose. Everything else that I know currently is 2 doses, either 3 weeks apart, 4 weeks apart. AstraZeneca, they've gone up to 12 weeks, I think, apart. But and I think I saw a question about the second dose causing symptoms. For the mRNA vaccines, they have the second dose is worse.
Yeah, we'll come to that. So, you know, we've heard about, you know, people mentioning that these vaccines cause so many side effects, and so you hear people making videos saying that don't take it because there are so many side effects. Can you address some of the known side effects and kind of address how safe these vaccines are? And I know you mentioned, you know, over 200 million people have been vaccinated, and you know, so if you can kind of put some meat on that.
Sure. So most of what people call side effects are not actually side effects, right? They're what your body is supposed to be doing when it gets exposed to an antigen. So you'll have the local reactions. You'll have pain and swelling and redness on the site. You'll have lymph nodes that become bigger because they're making antibodies. So that's expected. Or your whole system kind of goes into overdrive. You get fevers, you're tired, headaches, chills, muscle aches. So that's good. When that happens to you, you don't have COVID. Or some people will say, I got the flu vaccine and I got the flu. You didn't get the flu. Your body did what God created it to do, and those are the side effects. So for the mRNA vaccines, what we've been seeing is that about 80 to 90% of people will have these local reactions or systemic reactions. And after the second vaccine, it's slightly more. So we do expect that. One of the things that came out recently for the mRNA vaccines that we didn't really see much of in the clinical trials was what we call anaphylaxis, which is a very rare but severe allergic reaction to the vaccine or its components. And so that has now, the companies have now, added those to the label, because what we saw was that in about 2 to 4 people per million. So if 1 million people get vaccinated, 2 to 4 will have anaphylaxis. And at least in the US, nobody has died yet because it's treatable. So that is one rare side effect. Now, in vaccine safety, there's always things that happen that people think are related to the vaccine that may not be related to the vaccine. So what I'll say is the best way to figure out what happened to people in clinical trials is to look at the fact sheet, because on there it'll say in the clinical trials, for example, for Pfizer, we have 4 cases of Bell's palsy. But remember that we have people who have this all the time, like just going about their usual business. It happens when you get an infection. It can happen just spontaneously. So what we do in vaccine safety is that we look at these two. We look at the number that happened in the clinical trial or when the vaccine was distributed. And then we look at the background rate of this side effect. And at least for all of them so far, the background rate is more than seen in the vaccine. And that is why we can definitively say this is not related to the vaccine. But there's always ongoing, we're always looking at this in vaccine safety, because we realize that vaccines are given to healthy people and we want them to stay that way. And so that's why we look at every case of a rare side effect that happens very carefully to try to see, could it be caused by the vaccine?
Dr. Bomblatt, can I quickly ask a question? So this side effect that you are talking about, is it like the way my children would react when they've had the vaccine and I just have to give them Calpol? Is it?
Exactly. So these are the side effects that we're saying your body is having a big word, but reactogenic reaction to the vaccine, right? It just means that it's doing what it was meant to do. And you can take Tylenol, you can take paracetamol, you can take, and that's fine. And that'll help you feel better. But that's what your body's supposed to do. So that's a good thing. So you should actually say, thank God that I'm having these reactions when they do happen. We'd be worried about you if you had no reactions.
So Dr. Ayi, maybe you can say something here. There was a question about the second dose. I know Dr. Bomblatt kind of addressed it a little bit. Can you just put a little bit of meat on it? Why is it that the second dose, kind of gives more of a reaction than the first dose?
You're muted.
I didn't experience any reaction after the second dose besides a little pain at the injection site. And I've heard some people talk about it. I suppose it's because you need the second dose to actually mount that immune response, because that's what they've said all along, that you need the second dose to actually build up the immune response. So I honestly don't know why some people are getting more sick after the second dose, unless someone else knows.
I can touch on that briefly. So one thing about the second dose is actually the boost. So when you get a boosting dose, it means that your body is already primed. And so the reaction that you're going to get is actually going to be a lot stronger than the first one. One study that was recently published from people who had COVID before, and then unknowingly or whether knowingly got a vaccine, showed that those individuals also had similar reaction when they got their first dose, and a lot of people are talking about that. So overall, my second dose, if you ask my wife, she's going to laugh at me. I was curled up on the sofa because I was shivering like I had a flu. So yes, and I was telling her that, oh, yeah, it's crazy, but I'm happy that it's happening because I know that the vaccine is working. I had a similar reaction in the first dose, but not as bad. So yes, a lot of times for most people are going to get more of a reaction in the second dose. I collected some data on that, and I'm actually I publish on my blog soon.
Yeah. So thank you so much. You know, and I think just to add to that, you know, some people who have received the vaccine after having caught COVID, I mean, they've actually been shown to have 100-fold antibody titers. So that means they mount a really robust immune response to the vaccine, and so obviously the one of the questions that people ask is that, okay, if you've gotten the disease, then should you get the vaccine? And I think the answer is going to be yes. And maybe those people may need just one dose of the vaccine because they're already primed. So now let's move on and address some of the kind of myths and conspiracy theories. And there's been a question here about, you know, is it true that the vaccines contain some chip technology that makes the government able to track you or control you? You know, some people have kind of made it analogical to the 666 thing about, you know, getting the mark of the beast, and so scaring people. So can we address that, Dr. Baumblatt? Can you start with that?
So I'd say that if the government wanted to track us, they would do that with our cell phones. So that's the first thing. If you if you really want to get rid of something, some kind of tracker, then throw your phone away. So putting that aside, though, in vaccines, there is just no way to put a chip into, you know, like, so mRNA vaccines, there's the mRNA, there's some little fats, and then basically that's it. And so I don't even know how you would do that. Like, how would you put a chip into a syringe? Essentially, there is no chip. I don't know what to tell you, but just looking at the ingredients, it doesn't say chip in there in the ingredients when we're reviewing them. I don't even see, I don't know, there's no metals. There's no, it's, I think someone else can explain this better, but there just isn't a chip, and there's no way to track you except with your
The only tracking I'm aware of is the usual one where after you get the vaccine, you voluntarily, you can register with the CDC, and every week, at least the first week, they'll send you an email every day, and you put in your symptoms. And then after that, it's like every week for a while. I still get a message every week asking, but that's purely voluntary. Nobody forces you to do that. And it's part of the monitoring of the side effects. And that's just in the US. I don't know about the UK and other countries.
Yeah. So I think Dr. Baumblatt made a very good point. You know, sometimes people will try to create a certain narrative. I mean, if, you know, we are being tracked every day, and much more so on our phones than anything else. If the government, I mean, that would be a very ineffective, expensive, and useless way to track people by using a vaccine. We get vaccines all the time from the day we are born. And you know, vaccines have been around for a long time, and we, you know, for some reason, this particular one, people are trying to attribute things to it that are not true. And importantly, every click you make on your phone or on your computer, that is being tracked by the different companies, and the government surely has access to that. So if they wanted to track you, they have better ways of tracking you than using a vaccine to track you. And so obviously there's no truth to that fact that they are going to use a vaccine to track you. Dr. Ayi talked about the CDC thing, which is for tracking to see how many people have symptoms after they get the vaccine. And it's been a few weeks since I got my second dose, and I'm still getting weekly texts to fill up that question. So that's not an issue. So okay, so how about this whole thing about 5G technology, Dr. Soa? Initially there was a lot of talk about the symptoms of COVID-19 being similar to symptoms of radio, exposure to radioactivity, and the fact that 5G technology has a much higher radioactivity compared to 4G technology. Can you address that?
So one thing I'll say is that 5G and COVID have nothing in common. 5G technology has been with us for many years. So America is now moving in that direction. COVID pretty much came on the scene. So if 5G was the cause of COVID, we would have had COVID long ago. And so what I'll say is that 5G and COVID have nothing in common. And the fact that COVID is related to 5G, I don't know where people got that idea from. It's not COVID-19 is caused by a virus. We all know that, because when you get it, somebody who is next to you and close to you is more likely to get it. If it was 5G technology, when you get it and you go into a room or you're walking outside, anybody who comes close to you would get it. And as Dr. Bamblat and Dr. Ayi both said, when you are outdoors, you are actually much less likely to get COVID. 5G technology is spread. It's a technology that actually sends waves all over the place. If we look at the COVID numbers in the US, you can see that there are pockets and pockets all over that are clamps. If it was 5G, we would all be affected. So I pretty much do not have any evidence to say that COVID and 5G are related. All I can say is that they are not related. I cannot tell how people came by that idea, but it's not true.
So Mo, do you wanted to?
Yes, I wanted to ask you a question, Dr. Lai. I know we are all Christians here, but Dr. Lai, I know you've been a Christian for a pretty long time. So my question to you is, to the viewer out there who thinks actually this session is just a waste of time, who thinks that this is just a distraction from the enemy to stop Christians from preaching and focusing on the main thing that Jesus asked us to do, that is to heal, to teach, and to preach to the sick. What do you have to say to them, Dr. Lai? Now, I want you to tackle this both as a Christian and as a medical doctor.
Okay. So, the important thing is, as I've said so many times on this forum, God has called us and given us a mandate, right, to reach the world. However, we cannot do that if we are sick in the body, right? Now, the interesting thing is that since COVID became a pandemic about a year ago, we've seen so many things. There was this story about some African, preacher who believed that, God's power was greater than COVID, and so he was going to pray for COVID people. He ended up dying, right? And currently, with the uptick in Africa, we're seeing a lot of people dying. Pastors are dying. believers are dying, and so if we don't take precautions, and it's interesting if you look at in the days of Moses, the laws that God gave to Moses, and even up till now, some of it is being practiced. But you could see that people who had leprosy, right, were not supposed to come into the congregation. They were put outside. These are all things that are similar to the things that we are doing, talking about social distancing, like quarantine, isolation, when you're exposed. So even God in his wisdom in giving kind of laws and and telling the people of Israel what to do, there were some of these things in there about diseases that were contagious, and having people be quarantined or be outside the camp. Okay, so the truth is that as a child of God, you need to understand that you have a role to play, not only in reaching souls, but in making sure that people are well. I mean, God is concerned about healing, right? And God can heal either supernaturally or he can heal through medicine. And God has given us the wisdom to do all these things. And as Dr. Mombla said, we should consider it a miracle that just this short into a pandemic, we have several candidate vaccines that have been shown to be effective. And this is a way for us to get the herd immunity that we were talking about, so that we can go back to doing our business. Now we can see in different countries, there are lockdowns. You cannot have church services. How are you going to do your work of ministry if you can't have church services? But if we can get this pandemic under control, you will be able to do that. And so to kind of put it all together, this is not a waste of time. This is really important, because a lot of people are having to, they've lost their jobs, they've lost their sources of income. A lot of people are having to be shut in, and they are hungry and they are depressed, and so many things are going on. And the sooner we can get this under control, the better it is going to be for us as children of God to be able to reach our world. And so if we kind of follow the myths and the conspiracy theories, we are actually going to do harm to the kingdom of God, because then people are going to see, that pastors are dying. The same people who are talking against this are ending up, dying. And that's not a good testimony to have. So I think to move on, let's address vaccine hesitancy. Okay. And just like it kind of goes to the bottom of the question that Ma just asked. So we know that there's vaccine hesitancy among different groups, especially minority groups, because in the past there's been some history that makes people kind of wonder if they are going to try to get rid of, say, certain populations by giving them the vaccine. Even before I asked the question, I would say that if that was the case, the politicians will not be the first in line to get the vaccine. We all know that when the vaccines came, the first people who got in line to get the vaccines were the politicians. If it was a means of getting rid of certain minority populations, they wouldn't be getting it. So let's address vaccine hesitancy. And I think I will have everyone talk about it, as it relates to Christians, the church. Some pastors have been preaching about, telling their congregations not to get it, just based on some of these myths and conspiracy theories out there. So, and then let's address it from kind of the minority racial points of view, and how do we get beyond that vaccine hesitancy, and how can we get more people to get vaccinated? So I think I'll start with Dr. Bonblatt, and then Dr. Ayi, and then Dr. Soa.
Yeah. So I do think it's a big issue. I recognize that there's a precedent for, people don't just wake up and distrust something, right? Like there's a history, there's a past, and so that does need to be addressed. But the bigger issue is this. Typically, we don't hear people telling someone who has diabetes to not take their medication. Typically, I mean, maybe there are some, but in our circles, it's accepted that if you have diabetes and your doctor says take your medication, you take it. Or if you have hypertension and you're treated with it, you take it. So it's kind of the same thing. It's a medication and you're taking it. It has side effects, right? But not taking it is worse. Like that's the issue here. So we have a pandemic that is either killing people or giving them really bad disease or overwhelming our healthcare system. So you have a vaccine that could prevent that or help. And it's a very good one. And it's been in millions of people and it's safe. I don't see the argument for why you're okay taking other medications that have also been produced by these same companies that also have things in them that you don't know, but then you're not okay taking a vaccine. So I think people should really think through clearly. If they're hesitant, you need to be able to explain to yourself why. And if you start to actually look at the data, you won't be able to explain why, except if you just dig in your heels and say, well, this is what I believe. But our faith calls us to be, to use our minds, right? Like God gave us minds and we can use this. There's enough information, enough data out there to be able to see what is true and what isn't. So I would just urge us as Christians to use our minds, right? To be intellectually rigorous and to do the work. And you will come out on the side of, well, this is clear, right? Like there's a vaccine, there's an illness, it prevents it. I should take it and do my part. So that's what I would say.
Okay, Dr. Ayi, you want to address?
Okay, yeah, I'll just throw in this. Thank you, Dr. Bonblatt, for that generous answer. And I'll just like to add, if you remember when the children of Israel were in the desert and they disobeyed God, he sent snakes to bite them. And when they cried out to God, God told Moses to make a rod out of a snake. So when they looked at it, those who got bitten just looked at it and they got cured. It was almost like a vaccine or an anti-venom for the venomous snakes. He didn't take the snakes away per se, but he told them what to do. And whoever looked at the snake got well. And there was a woman who came to Jesus who was blind. Jesus rubbed some saliva with salt and put it on their eyes, and they got healed. So it's not uncommon to use something physical to treat an illness. And I'll just spin up onto smallpox. People ask, how did vaccination even start? And I always go back to smallpox because smallpox was the first disease for which a vaccine was made. It was the first disease which was eradicated with a vaccine in 1980. And it is also the same disease that I always ask my audience. The United States has 300 million doses of smallpox vaccine waiting to give that to anybody who would develop smallpox, God forbid. The US and Russia also have the world's only stock of smallpox in the world, enough to infect everybody if needed. If vaccines were such a bad idea, why would the United States stock 300 million doses of smallpox vaccine? Because it works. So let me just go briefly the history of vaccines. Smallpox was affecting people for thousands of years with a mortality of 80%, and people didn't know what to do. And a few people observed that there was a disease affecting the breast of cows. It was called cowpox, and milkmaids who took care of these cows were somehow protected from smallpox. And so Edward Jenner had this idea that if I can take some of the fluid from somebody with cowpox and put it on people who have not been infected with smallpox, they would become immune. And vaca is the word for cow, and vaccinia is the Latin word for cowpox. So it is out of this vaccinia that we have vaccination as we know it today. And out of Edward Jenner's experiment, people started rearing large amount of cows, infecting them with cowpox so that the serum could be used to vaccinate people. And it was life-saving. By 1980, smallpox had been eradicated from the world. Since then, as of today, there are over 40 vaccines for different illnesses, from cholera to mumps to Dr. Soa talked about influenza and many other diseases. We don't even question them. The thing I want you to note is that Edward Jenner had an idea. Let's use cowpox to protect against smallpox. Since that time, people have thought about, okay, let's attenuate or let's kill maybe influenza virus, or let's take a portion of this. The world runs on ideas of people trying to innovate and solve problems. So 2020, we've had COVID-19, and people have thought, well, maybe mRNA might be a good platform. And so they're using it, and suddenly people are afraid. But I want to encourage people not to be afraid, because all these diseases that have been eradicated or been solved with vaccines, it was based on people coming up with new ideas. So the fact that mRNA is a new idea does not make it any dangerous or a tracking mechanism. It's just another idea. And the data from the study shows that it's effective. Those who are vaccinated are protected from hospitalization and death. And I think that in the past, COVID deaths were far away, but now it's hitting home. People know family members, friends who have either died or recovered or almost died. And so I think that it is better to be vaccinated and protected 95% of the time than to be infected with a disease which has a good chance of causing death. And Dr. Opariloko also was asking about pregnant women. A lot of the women who were on the clinical trials, even though they were told not to get pregnant, some of them went ahead and got pregnant, and nothing has happened to them or their babies. In fact, they're starting clinical trials on pregnant women over the next few months, and even children below up to the age, up to 5 years old. And so we'll be getting more data to show that these vaccines are safe and they're effective. And so I want us to just remember the smallpox, that if vaccines were that bad, US wouldn't store enough to protect its whole population. And so I just want to encourage you, go out and get it. Wherever you live, Ghana, Nigeria, there may not be enough vaccines around, but at least in the US, over 40 million people have been vaccinated. Yeah. If it was that bad, people won't be queuing for it. So go out there and protect yourself. Do yourself a world of good. And if you protect yourself, you won't get severely ill, and you protect the next person too.
So, Dr. Soa, let me kind of put a little slant here. So since we've talked about pregnant women, now how about patients who have cancer or weakened immune system like HIV? Should they get the vaccine?
So, Dr. Jonathan, that's a very good question, and it's a very important question, mostly because when you look at the number of the people that are at risk or of severe disease, cancer patients and people with diminished immune system are part of that group that we worry about when it comes to COVID. So far, the studies do not show that these individuals have any added risk from the vaccine. What we do not know, though, is how well they are going to respond to the vaccine, but it doesn't mean that they should not get it. What it means is that they should get it, even though we do not have enough information to know how well they are going to be protected. We do know they are going to be protected. We don't have the numbers yet. So I'll say, if you have cancer, if you have HIV, if you have any disease that weakens your immune system, I'm more worried about you. You should be getting the vaccine as soon as you can. And then I would like to also say a little bit about the hesitancy, because a lot of people are worried, and I do not blame you if you are worried because you say mRNA is new. But what I'll say is that if we have to wait to go through the same process that we normally go to get vaccines, it would have been longer. I'm happy that we have an mRNA vaccine, and I'm happy that it has so good efficacy. So if you are hesitant, I'm here now. I got a vaccine. I'm feeling good. I didn't have any problem with it. I know people who've had the vaccine even earlier than I got it, and they're strong. I have a friend, he always teases me and say, "Oh, I've not changed into anything. Did I change to anything?" He's still there. He's doing well with the vaccine. And before I go, I'd like to add something a little bit about the history of vaccines. There is a black guy in Boston who actually introduced the idea of vaccination in the US even before America became independent. It's called Onesimus. And it was an idea that was being done in Africa. Smallpox has been around for a very long time. Even before cowpox came, people knew that if somebody got smallpox and you took some of the scab on the skin and you cut your skin and put it in there, you got sick. But you didn't get small. Some of the people unfortunately died, but the rates at which they died from that smallpox inoculation was a lot lower than people who died from the disease itself. So that was used for a long time until cowpox was identified as a safer version. Some people believe that that idea was what allowed Americans to actually fight the British during the War of Independence in the US. This was something that was known, but people didn't want to do it because they were scared. Benjamin Franklin was the one who pushed for that to happen in the midst of the war, and that actually helped the US troops, fight the British, because the British had a lot of experience with smallpox. The Americans didn't have as much experience. The smallpox was killing them. And this helped. It's just a story. You can look into it and it's true. So vaccination has been with us for a long time, and we are getting better at it. We should thank God for that.
So there's a question from Bishop Maya from Suriname saying, is it safe to administer COVID-19 vaccine to people who are already sick in general or who show symptoms of having COVID-19?
Yeah, we say that you should not get vaccinated if you're currently having symptoms of COVID or any other symptoms for that matter, for flu or anything else. But once that is over, there's no reason why you cannot get vaccinated. However, when there's a limited supply of vaccination, because you do have some of your own immunity, we think for up to about 3 months. If there is a limited supply, it would be okay for you to not be the one, to go forward. But there's no reason that you couldn't get it unless it's limited and there's someone else who hasn't had it, who really needs it ahead of you. And that's more on a local level how that happens. But there's no reason why you can't get vaccinated. In fact, you should get vaccinated after your bout with COVID.
Yeah. So it sounds like, a lot of people are kind of wondering when it will be the turn of everybody to get vaccinated. So currently in the US, it's kind of healthcare workers, frontline workers, as well as the elderly in nursing homes and those over 70 that are getting vaccinated now. And so is there, I know, you may not necessarily have the inside information, but from the standpoint of guessing when will we have enough vaccine for everyone who is eligible?
I can jump in there. I think from a report that Dr. Fauci put out there, we are hoping that by April, there will be vaccination is going to be open generally to everyone. One thing too that is happening now is that they are actually trying to ramp up production of the vaccines. And also, as we also know, more and more vaccines are also going to be available as time goes on. So hopefully by summer, most people should actually have had a chance. We're hoping to do that, but it's just a hope. And if people don't step up and get vaccinated, even if these vaccines are there, it's not going to happen. So we need people to actually be ready. When you are called, Don't say, I'm waiting to get this, I'm waiting for this, just get it.
I think there's somebody just posted a comment. Amma Bilsinogo said, I had my first dose of the vaccine last Sunday, and apart from slight pain at the site, I'm perfectly well. I had COVID in December, but I have underlying medical condition, hence being in the top 5 group. I live in the UK, and I'm just shocked that some of my friends refuse to get the vaccine. And this is being preached in some churches. Amma, thank you for sharing your story. I think it goes to, to kind of beef up what we've been saying all along. And I think you can also be an advocate and tell your story so that people will know that, yes, you can get the vaccine even after getting the disease. And also, importantly, we have to understand that, there is no tracking technology, there is no nefarious plan. And again, as we've said, if there was a plan to track you, you're already being tracked. And there are more effective ways of tracking you, because with your cell phone, I mean, even your movements are tracked. They can know what you were doing, if you were moving your hands, or if you were, so that's not a thing to be afraid of. Now, George, yes, this is somebody I went to school with, George Gizeno, says, which of the vaccines will prevent the new variant from South Africa? So again, at this point, I don't know if I can be very direct with that. However, the vaccines that had trials in South Africa, like the Novavax, and I think one of the adenovirus vaccines was also trialed in South Africa. All those ones showed efficacy against the South African variant. And so I'm pretty sure, I think George lives in South Africa, and whichever vaccine will be approved in South Africa will have efficacy against that. I don't know if any of you want to address that too.
I do know that South Africa tried the AstraZeneca and then changed quickly to the Johnson & Johnson. They did some small studies, and they found out that the Johnson & Johnson that did a lot better. So that's what I know they are using now. But with time, the mRNA vaccines have not been used widely, mostly because of the storage. But with time, we have more data to show whether they are also effective. And I know that as of now, work is being done to actually possibly change the code for the mRNA vaccines to be sure that they actually would be effective against, or fully effective against, the variants. So there's a lot of work being done to target the variants at this point, but there are still vaccines that work. They may not work as good in the old variant, but they still work.
So there was another question about which vaccines we've taken. I took the Pfizer vaccine. I don't know if you guys want to talk about it.
I had the Moderna one.
You had the Moderna? Okay.
Yeah. I mean, here in the US, it's just whatever is available, what was given to your state and what was given to your hospital. So my hospital had Pfizer. We had no choice in the matter. Another military hospital had Moderna. So, I mean, I don't think it matters, but I don't think we're having much of a choice here at this point.
And I took the Pfizer vaccine. And just to put a little perspective, I think the Pfizer and Moderna has been tried on the South African variants, and they've been shown to be effective. The ones that did not have very good results was the AstraZeneca at, I believe, 57%, and the Novavax, which also wasn't extremely effective. But, like we said about the influenza vaccines, even 50% is still very good. And the other thing about the South African variants is that they found that the monoclonal antibodies don't work at all against them.
Yeah.
So they don't use them over there. And that's just a little spin on that.
So there's another question about vaccine passport, and I think people kind of raise certain issues. So I mean, if you talk about vaccine passport, it's no different than what is happening now. Anytime you travel, especially when you travel to Africa and the developing countries, you have to have your yellow fever card. You have to have your vaccination card to show that you've been vaccinated. Otherwise, when you get to the airport, you are going to be whisked away, and then either you pay and get vaccinated there, or they will repatriate you. And so at some point, and currently what's happening is, in traveling to different countries, they want you to actually get the test within 72 hours of leaving. And then when you get to your destination, some countries, they are even testing you again in the airport. So that is the equivalent of a vaccine passport if this is even more rigorous. So the issue is they want to make sure that travelers that are coming in are not bringing COVID with them. So, definitely I suspect and I believe that governments are going to say, well, if you've been vaccinated, then you may not have to do the test before you come in, and you have to have some way of showing that you've been vaccinated. So if people talk about vaccine passport, this is something that's been going on. If you've been a traveler, you know that this has been going on a long time. And if I should tell my story, one time I went to the Democratic Republic of Congo, and I had my vaccination card, my yellow fever card, but apparently I picked the wrong one, the old one. And so I got detained at the airport, and they were speaking French to me, and I didn't speak French. And so they had to go bring someone, and I had to explain that, look, for me to get the visa, I had to show them a copy first, and I just by mistake picked the wrong one. So the issue of vaccine passport is nothing new or anything to be worried about, because it's happening even at a worse rate in terms of getting tested and getting retested when you arrive at your destination. Okay, so I think we are coming towards the end of this program, and I think it's been very informative. So I will kind of let Maud kind of take up if she has any other questions. But
I have just one question, Professor Lai. So what is it about ginger, steam, garlic? There's another a herbal tea which people are circulating that it helps prevent COVID. Please, could you tell us a little bit more about it?
Okay. Does somebody want to take it off? Okay, so there is this thing about ginger and garlic and all those things. Now, one of the things that happens with COVID is that with the inflammation occurring in the airways, there is thick mucus that tends to plug the airways and prevent kind of air exchange. And so there's been, in fact, a study that was published from South Africa where they were doing what they call bronchoscopies and suctioning out this, and patients doing better. So what the steam therapy does is that it helps to break up the mucus and makes it easier to expel them. And ginger, for example, is an irritant, to the airways. And so with the heat kind of breaking the thick mucus, and then the ginger and other ingredients being irritants kind of makes you cough so that you can get rid of the thick mucus. However, the steam does not kill the virus. In fact, that has been one of the things that people have been saying. Yes, it's helpful in getting rid of the symptoms because the congestion and all that, you're able to clear the mucus, but it does not kill the virus as some people claim. I don't know if anyone else wants to add to it.
All I'll say is that a lot of these things have not been tested enough for anybody to be able to say if they work. And at this point, the only things that have been tested that we know would prevent you is social distancing, which has been tested. People have also done testing about masking and shown that those things are effective. And then we have the vaccines. So I'm not saying that these things don't do them if you want, if you can do it. But we don't have any evidence to say that this works. You know, you may just be wasting your time or wasting your money. So that's all I'll say.
Okay, so can we, somebody said, okay, Amma is saying she drank all those things and she still got it. Again, as we said, it helps with the symptoms, but does not necessarily kill the virus. So can we have everyone kind of give their final, statements, just whatever comes to mind about what we've discussed and what you want people to take away from this session.
Yes, please.
Yeah, and maybe I'll just give my final comment based on what Amma Bilsinogo had said. I was going to say that, but I didn't want it to be. I know a family member who, together with her husband, they decided they were going to do twice a day steam inhalations. She ordered sobolo from Ghana. She was chewing ginger and all these things every day, and she still got severe COVID and ended up in the hospital. So afterwards, she was laughing that, what did all that do for me? And I mean, I hated to bust her bubble, but the truth is, you have a virus that you can get exposed to in a 24-hour period at any time. Why do you think that if you do twice a day steam inhalations, you would prevent yourself from acquiring it? I mean, it could potentially kill the virus in your nostrils, but you're looking at a virus that you can acquire at any time, and it could multiply deep down in your lungs. So much as, and some people get very, very angry when you tell them that these things will not work. So over time, over the last year, I've learned to be politically correct and just keep quiet, because I mean, I'd rather have people, just do what makes them happy than to disrupt their paradigm of what they believe is the right thing. And the final thing is, if somebody has COVID and you stay 6 feet away from them, you will not get it. So let's practice social distancing. And if you have an event, this past weeks, I saw people organizing things at Akosombo, people are doing weddings, all sorts of things are still going on that shouldn't be going on. And so if you have an event that you can avoid inviting a lot of people to, please try not to encourage gatherings, and let's reduce them. Thank you.
Okay, Dr. Bonblatt.
Yeah, I guess I would say one thing that is one thing that's really big for me is that this pandemic has really shown, as Christians, where we place our trust, and what we're doing with our minds. So one of the things that I always go back to is when scripture says, love the Lord your God with all your heart, with all your soul, and with all your mind. And I feel like while we do a really good job with our heart and our soul, and we're really, we're really gung-ho for the Lord, we fail sometimes to love the Lord with our minds. Because some of these things, when you hear them, it should just click right away that it can't be true, right? So when someone says a conspiracy, you should be able to challenge that because you have a mind, right? The Lord gave us minds. And so I would say a really great step is what everyone is doing now, which is listening to conferences like this, reading up on the vaccines, looking at the studies, asking your physicians and other people that you trust to tell you the truth. The more you educate yourself, the more you can really speak about these things, speak about the vaccine, speak about medicine and what it's doing versus the pandemic. Look at the numbers, look at the people who are dying, look at all of that. And this is truth too, right? This is God's truth too. And we should be able to to look at these data as this is what God is giving us. We can look at this and use our minds to know that there is a pandemic, it's killing people, there's a vaccine, and other preventive methods that we should use. And so as Christians, it's all the above. It's not just we want to go to church, so we're going to, not wear masks and we're going to do all these other things. That's not loving the Lord with your mind. So that's the one thing I would say.
Okay, Dr. Soa.
One thing I would like to add before we leave is that when it comes to vaccines and also when it comes to new technology, there are always going to be some people who are going to be a lot more slower at actually being ready to actually adopt these new technologies. And some of them are not really conspiracy theories. They just are a lot more deliberate when it comes to making decisions or changing to something new. And on top of what we are worried about when it comes to past issues with race in the US, there is also the added thing that a lot of people pretty much want to take time to jump onto something new. And we as healthcare providers, and even all of us in the community, when you know somebody who behaves like that, all you need is patience. And when I say patience, you don't have the whole year because this person needs to get vaccinated. But the patience means that patience to listen to them without interrupting them, trying to understand why they actually would want to wait. And when you have that kind of patient attitude, a lot more people would come back and say, "Oh, I already took it."
Yeah.
When they decide, they don't tell you, but just listen to them so that you know why. Just showing them that you want to understand why they are making that choice. And I've seen a lot of people call me, or when I talk to them, I'm talking to them about something. So like, "Oh, see, I got a vaccine this weekend. This is how I'm feeling." And these are people that were initially resistant. And I just realized that a lot of people need time, and also they need time, and also they also need some degree of autonomy. So don't push very, very gently if you have to push. That's all I was.
Sure, thank you. So I actually want to give a shout out to Dr. Ayi, because when this pandemic started, even before it was called a pandemic, she was on a crusade about kind of the world having a concerted effort and a coordinated effort to contain this virus. I don't think she was heard. I believe that if the world had listened to a campaign of having a global concerted effort, we would probably be in a better place than this. I mean, it was right from the get-go. She started writing articles. She was doing webinars talking about this. And so, Dr. Bertha, I give shout outs to you. I think the world should have listened to you when you were crusading for a concerted effort. And I think we are all the wiser now, knowing that if the world had had a more coordinated effort, we would have, nipped this thing in the bud, much more quicker than it has been. But once again, we've come to the end of another wonderful webinar, and obviously COVID-19 and the vaccines have engendered a lot of conversations around the world because of a lot of misinformation and myths. And I would want to say a big thank you to our panelists, Dr. Forbes, who had to leave early, Dr. Bomblatt, Dr. Ayi, and Dr. Soa. And I will hand over to our august host, Mrs. Modlate.
Of course, and how can we end this program without saying a very big thank you to Professor Lai? Thank you so much, Professor Lai. We really appreciate you. Thanks so much. The viewership is amazing, and the comments coming in. I have learned so much myself, and I believe that when parents ask me a bit more about the vaccine, I'm in a much better position to talk a bit more about it, and to my children as well as family. So thank you so much. We're just going to end the program now with an advert, and then we are done. Thank you, viewers, for joining us once again. God bless you, and see you next week. Bye.
Thank you.
Since its foundation, Global Wisdom Academy's vision has been wisdom-centered, wisdom-focused, and wisdom-driven. we are partnering with Oral Roberts University's Bible Institute, whose central vision has been the mandate God gave to Oral Roberts to raise up your students to hear my voice, to go where my light is dim, where my voice is heard small, and my healing power is not known, even to the uttermost bounds of the earth. Their work will exceed yours, and in this I am well pleased. Global Wisdom Academy will fulfill the vision by partnering with ORU Bible Institute. For those who cannot come to Oral Roberts University, yet still have the desire to get equipped for ministry and to deepen their walk with God, Global Wisdom Academy offers an online strategic leadership certificate program administered through our virtual classroom. We structured this program to enable leaders and ministers to think creatively about the contemporary ministry and leadership and modern-day leadership issues. With support from our professors and PhDs and faculty members, the program will involve lectures, seminars, and practical sessions. The program will provide transformational, personal, and ministerial development and leadership at a time when it is needed most. This program includes a digital transformation course and social media studies, which will provide a valuable opportunity for core ministry functions and teach the students how they can effectively stream live on various social media platforms, resulting in church growth. To register your interest, visit www.stlglobalwisdomacademy.com.
Was it ended?